Good morning, everyone, and thanks, Dr. Rogers, for setting up the stage and the kind introduction. As the topic for my talk today is defining the epidemiologic scope of cardiometabolic syndrome, I made a slight tweak in the title, and I'm going to talk about the epidemiologic scope of cardio-kidney metabolic syndrome because as a heart failure doctor as well as a cardiometabolic investigator, I think the kidneys have been increasingly recognized to play an important role in development of heart diseases. So these are my disclosures. So advanced aging has become increasingly common throughout the 20th century, and over the last 100 years, we have seen an evolution in the most common cause of disease and mortality in our society. This so-called epidemiologic transition from a high burden of infectious diseases that was seen in the early 1900s to the mid-1900s to now a high burden of non-communicable diseases that are encompassing cardiometabolic syndrome, chronic coronary artery disease, heart failure, and so forth. And because of the decline in early mortality from infectious diseases and other communicable diseases, there has been an aging of the population, and the number of individuals at risk for developing non-communicable diseases such as cancer and cardiovascular diseases has become much higher. And this is also reflected in the lifetime risk of cardiovascular diseases like heart failure and coronary artery disease. And these data come from some of the seminal work done by Donald Jones in Framingham Heart Study. And as you can see, the aging of population has translated into a very high lifetime risk of cardiovascular diseases. And 1 in 4 individuals develop heart failure in their lifetime in the US, and 1 in 2 almost develop coronary artery disease. In addition to the increasing prevalence of cardiovascular diseases, a more alarming trend that has been recently observed in the past few years has been with respect to the rates of cardiovascular disease-associated mortality, as shown in this trend plot here. So on this plot, we have age-adjusted mortality rate related to cardiovascular disease, heart disease, and stroke on the y-axis, and on x-axis, we have time. And the plot here shows that between 2010 to 2019, there was a steady reduction in cardiovascular mortality by around 9%. However, since 2019 up till 2022, there has been a surprising increase in cardiovascular mortality by another 9%, such that all the gains in cardiovascular mortality reduction that we had in more than a decade has been lost over the last 3 years. And the excess death due to cardiovascular disease has been more noticeable among younger to middle-aged individuals between age of 35 to 54 years. And this highlights the worsening cardiometabolic health crisis that we are currently undergoing and suggests that we have to treat the cardiometabolic health crisis as a crisis of pandemic proportions and need some urgent interventions to mitigate the growing burden. So there have been several key initiatives launched recently to address this growing burden of cardiometabolic disease. Specifically, one of the most important initiatives taken by the American Heart Association was the Cardio-Kidney Metabolic Health Presidential Advisory that represented a key step to defining the scope of the problem. So in this scientific statement, the leading experts in this space actually came together and came up with a definition for cardio-kidney metabolic syndrome and identified it as a health disorder attributable to connections among obesity, diabetes, chronic kidney disease, and cardiovascular disease, including heart failure, atrial fibrillation, CAD, stroke, and peripheral arterial disease. And CKM syndrome includes those at risk for cardiovascular disease and also those who have prevalent cardiovascular disease, highlighting the entire spectrum of progression of these conditions. And the advisory also identified multiple stages of cardio-kidney metabolic syndrome. And I'm sure you'll see this slide multiple times today, which just highlights how important this staging concept has been in our understanding of cardio-kidney metabolic syndrome. And as you can see in the slide, there is a stage 0 when you have no risk factors, stage 1 when you have excess dysfunctional adiposity, which is often considered to be the first insult in progression of cardio-kidney metabolic syndrome. And then you have progression to stage 2, where you have metabolic risk factors and CKD like hypertension, metabolic syndrome, hypertriglyceridemia, evidence of kidney dysfunction, and hyperglycemia. And then stage 3 is when you develop subclinical cardiovascular disease as a result of long-term exposure to these risk factors. This includes subclinical evidence of atherosclerotic cardiovascular disease as observed by coronary artery calcium, or subclinical heart failure, diastolic dysfunction. And then stage 4 is the clinical manifestation of cardiovascular disease in the setting of CKM syndrome, which is largely an event of heart failure hospitalization, or an acute myocardial infarction, or a stroke, or atrial fibrillation. So with this understanding, now there has been a lot of work being done to understand the true burden of different stages of cardio-kidney metabolic syndrome in our community. And one of the recent papers from the group in, I think this is in Boston, came up with the actual burden of CKM syndrome over time using the NHANES data. And as you can see in these data, where you have time on your x-axis and the CKM stage prevalence on y-axis, you can see that 74% of NHANES participants had stage 2 or higher CKM. So they had either risk factors or downstream development of subclinical or clinical cardiovascular disease. And up to 15% had advanced stages, so stage 3 of subclinical cardiovascular disease or actual clinical cardiovascular disease. And this is a population representative sample highlighting how complex and how high the burden of CKM syndrome in our community is currently. And it is also important to note that the CKM syndrome does not happen in isolation, and there's often clustering of conditions like obesity, hypertension, diabetes. And these data also come from a group at Brigham and Women's, where they looked at clustering of kidney, cardiac, and metabolic conditions, and identified that up to 22% of NHANES participants had more than one cardio-kidney metabolic condition, largely reflecting the common risk factors that predispose one to developing these conditions. So now that we know that there's high burden of these cardio-kidney metabolic conditions, we have to dig deeper and understand how the community is doing with respect to burden of individual risk factors that can be targeted for prevention. So these data also come from a recent study from NHANES, where the investigators looked at the prevalence of hypertension, diabetes, hyperlipidemia, and obesity, the 4 cardinal cardiovascular risk factors, which are key components of the cardio-kidney metabolic syndrome, in the general population aged between 20 to 44. So these are relatively younger individuals who were participants of the NHANES study. And as you can see here, the prevalence of hypertension since 2009 to 2020 has gone up a little bit. There has been also an increase in prevalence of diabetes and a much more substantial increase in prevalence of obesity, which is shown in the bottom right graph. And hyperlipidemia prevalence has more or less stayed steady to downtrend a little bit, which largely reflects the prevention related to statin use. So suggesting that of the 4 conditions, 3 have either gone up substantially or to a significant degree in the last decade. And if you look at the risk factor burden by racial ethnic minority groups, you see that there is a disproportionately higher burden of risk factors like hypertension and diabetes and obesity among individuals who are of self-reported Black race or of Mexican American ethnicity. And if you can see that these subgroups, which are shown by either the orange line or the blue line, so for hypertension, the prevalence of hypertension is markedly higher in the Black race individuals, and prevalence of obesity is higher in both Black race as well as Mexican American individuals, suggesting that it's not that these risk factors are growing in the same magnitude across different race groups, but they are disproportionately affecting the socially disadvantaged groups a lot more. And this is also reflected in this subsequent data that were presented in this paper, where individuals of Black race had a 2-fold higher risk of having prevalent hypertension and up to 2-fold higher risk of having prevalent diabetes and around 1.3-fold higher risk of having obesity compared to individuals of white race. And similarly, Mexican American individuals had up to 2.5-fold higher risk of having diabetes and up to 1.5-fold higher risk of having obesity, suggesting the disproportionate worsening in the risk factor burden among individuals of racial ethnic minority subgroups. And this disparity is not just evident by race groups, but also by socioeconomic status. And these analysis results are also from the same investigator group in BIDMC Boston, and they looked at the burden of risk factors by high and low income status. The low income status here is shown by the light blue line, And again, we have time on the x-axis, and these are data from NHANES, and you can see a substantially higher burden of hypertension, diabetes, and obesity in individuals of low-income group, and the burden has gone up more in the recent years in the low-income group as compared to the high-income group, again highlighting that the burden of these risk factors is affecting the individuals of socially disadvantaged groups and racial ethnic minorities a lot more. And it's not just the prevalence of conditions, but it's also the management and optimal control of these conditions that is relevant to development of downstream cardiovascular diseases. So recent data have looked at how well are we treating our patients with hypertension and diabetes, and how well is their blood pressure and glycemic control. And these data come from NHANES again, and as you can see here, up to 40% of individuals with hypertension and diabetes have no ongoing management. So the adults receiving treatment proportion is around 60%, and it has stayed steady in the last decade, as seen in the trend plot on your left. And the plot on your right shows the proportion of optimal risk factor control, and up to 20% individuals have suboptimal control of hypertension, and up to 45% have suboptimal control of diabetes, again highlighting that it's not just a problem of prevalence or development of risk factors, but also the management and control and access to care that we need to optimally manage these conditions. And the same largely stable trend has been noticed in the levels of low-density lipoprotein, the bad cholesterol in our blood, and this is also reported from the NHANES data that overall the levels of LDL in the community have stayed steady and have not really trended down, despite all the initiatives from AHA and ACC to increase use of statins in patients who need these therapies. And disparities also exist in not just prevalence of these risk factors, but the management of these risk factors too. And the data shown on these graphs show race differences in blood pressure control on your left, and race differences in use of novel diabetes therapies like GLP-1 on your right. And as you can see on the left, individuals of non-Hispanic, Black race and Hispanic individuals had much lower proportion with controlled blood pressure than those of white race. And similarly, the use of GLP-1 agonists is lower among individuals of self-reported Black race than those of white race, suggesting that the problems with disparities are not just in development of the disease, but also how we are managing it and how much access do these communities have for therapies that are needed for optimal management of these conditions. And this is also reflected in statin use, and these data come from our group from a couple of years back, where we looked at statin use among self-reported Black, white, and Hispanic individuals across the strata of cardiovascular risk. So on x-axis, we have subgroups of patients by cardiovascular risk, and on y-axis, we have prevalent statin use. And as you can see, across the strata of risk, in intermediate as well as in high-risk individuals, the use of statin was markedly lower among individuals of self-reported Black race than of white race, and also among Hispanic patients than non-Hispanic patients, suggesting that much work remains to be done in availing these therapies that we know work to patients who are at the highest risk of cardiovascular disease. And again, the disparities are not just by race, but race is largely a proxy for socioeconomic and social disadvantage. And as you can see, the analysis, when stratified by income level, also reflects that disparity, where low-income individuals are often undertreated for hypertension and diabetes than high-income individuals. And this is all very, very relevant because the worsening burden of cardiovascular disease that Dr. Rogers was earlier talking about has also disproportionately affected individuals of self-reported Black race. And these data come from a recent study published in Circulation, where the authors observed the premature cardiovascular disease incidence was much higher among individuals of Black race, both men and women, compared to white race individuals, suggesting that the cumulative effect of higher prevalence of risk factors as well as poor control of risk factors translates into higher burden of premature cardiovascular disease. So let's now talk about health behavior, because the central theme for having better management of cardiometabolic conditions is having healthy lifestyle and healthy behavior. And several guidelines have recommended at least 75 minutes of per week of vigorous physical activity or 150 minutes of moderate physical activity. And recent studies have looked at how well are we doing with adhering to these physical activity health behavior guidelines. And these data coming from NHANES again show that over 35% of individuals in the community don't do self-reported exercise to the extent that is recommended. And this is self-reported, so anyways, I think you can expect that they are over-reporting it. Even with that over-reporting, 1 in 3 individuals don't meet the physical activity guidelines. And over time, there has been an increase in the sedentary time duration, and this is probably largely related to advent of more and more screen time use in our daily lives. And sedentary time has increased from like 5.7 hours to 6.4 hours over the last decade. And the proportion of individuals not adhering to physical activity guidelines and reporting increased sedentary time has also gone up substantially from a 16% to 19%, suggesting that the health behaviors that we are seeing in our society are regressing or going in the wrong direction, and which probably could be contributing to the worsening burden of cardiometabolic risk factors as well as the CKM syndrome. And this differences in physical activity adherence is more highlighted by race groups. And as you can see in the red boxes, the individuals of Hispanic ethnicity and self-reported Black race have much lower adherence to physical activity recommended guideline recommended physical activity levels. And this is largely, I think, a problem of access and having access to safe spaces for physical activity and having access to areas where you can exercise and have recreational activities, which is much more limited for individuals of socioeconomically disadvantaged backgrounds. And that is also reflected, again, by socioeconomic status, where individuals of lower socioeconomic status and lower income have much lower adherence to physical activity levels of guideline recommended thresholds, as shown by this graph here, where only 16% of men and 10% of women who are less than 100% of the federal poverty line are actually adherent to the guideline recommended physical activity levels, as compared to 25 or 30% among those who are 200% higher than federal poverty line. And these trends in health behavior are not just limited to physical activity, but also to access to healthy food. And Dr. Sharma would later talk about how important it is to have access to healthy food for improving cardiovascular health. And these data come from a recent paper looking at food insecurity prevalence among individuals in the NHANES cohort over time. And as you can see, over time, there has been a significant increase in prevalence of food insecurity, and this has been worse among individuals with cardiovascular disease, suggesting that people who are having cardiovascular disease don't have access to healthy food and have higher burden of food insecurity, which contributes likely to worse outcomes. And I think this is an important area of focus that is needed to improve outcomes in patients with cardiovascular disease. So where are we headed? And Dr. Rogers briefly commented on it as well. I think if you look at the projections that were made in the recent AHA presidential advisory that came out in July, for burden of disease by 2050, it is predicted that the burden of hypertension, obesity, and diabetes is going to go up substantially if we continue on the path that we are on right now. And this is particularly relevant because the increase in burden of these risk factors will also be mimicked in the burden of cardiovascular conditions. So proportionately, it is expected that the burden of total CVD, heart failures, and stroke and CHT all is going to go up substantially in the next 25 to 30 years by 2050. And it is particularly also relevant that it's not just a problem of adults or older individuals, it's also being seen in children. So these data come from the pediatric population, where the proportion of risk factors like diabetes and obesity are considered to be substantial. But if you look at the obesity burden, it is expected to go up from 20%, which is in 2020, to up to 35% by 2050. And as we all know, obesity is the first stage or the second stage, stage 2 for the CKM conditions. So this sets them on the path for having accelerated chronic cardiovascular and cardiometabolic diseases. So what do we need to do and where do we need to be? So these data also come from the same AHA presidential advisory, where the investigators did a forecasting. And this is a really interesting exercise because it tells us how much risk reduction can we achieve with expected interventions. So the authors used here prevention impact simulation model to explore 2 potential intervention scenarios. The estimates represent reduction compared to the current assumed rates in the year 2050. So the first scenario that is shown in the blue bars assumes that the published targets for healthy people 2030 would be achieved. So if we achieve the set targets by AHA for 2030 healthy healthy hearts, which includes reduction in the prevalence of hypertension, hypercholesterolemia, diabetes, and obesity by 10%, and improving the control of these adverse conditions among those who have these prevalent conditions by 20%, you can get as much as 15% reduction in cardiovascular disease by 2050. And if we do even better and go to scenario 2, where you do everything in scenario 1, but additionally reduce the burden of obesity by half and double the risk factor control, you can actually double the risk reduction in cardiovascular disease and stroke events to up to 30% by 2050. So we have our targets set. We know what needs to be done, and we have a really nice map of how we can get there. And this was also shown by Dr. Rogers earlier. AHA has identified key essential steps that need to be taken to improve our cardiometabolic health. This includes adequate sleep, healthy diet, physical activity, control of risk factors. And it is really upon us now to develop innovative strategies to inculcate this in our population health management, because without this, we are on a steep trajectory of a pandemic of cardiovascular disease by 2050. And in patients who have these conditions or who have already got stage 2 or stage 3 disease, we now have really effective drugs such as SGLT2 inhibitors, GLP-1, and most recently finerenone, that have shown really strong evidence for improvement in risk of major adverse cardiovascular outcomes and cardiovascular death. So these data come from a recent analysis published in Circulation, where the investigators estimated the lifetime benefit of being on these 3 therapies if they have underlying cardio-kidney metabolic disease. And as you can see in the overall survival plot on your left, there is a gain of up to 3 years in overall survival if someone at the age of 50 is started on these therapies in the presence of these conditions. And if you look at the forest plot on your right, you can see the strong risk reduction associated with using these combination therapies as opposed to conventional care, with up to 36% reduction in cardiovascular death and 35% reduction in MACE by simultaneously using SGLT2 inhibitors, GLP-1, and MRAs in patients who have underlying cardio-kidney metabolic syndrome. So in conclusion, I would say that the burden of cardio-kidney metabolic syndrome is very high in our community and is expected to go up markedly in the next 25 years. And there are existing racial and socioeconomic disparities in the CKM syndrome and CVD burden that is widening over time. And conventional approaches to prevention and management have fallen short, and our subsequent speakers are going to talk about potential strategies that we can implement to improve the cardio-kidney metabolic management in our society. But we do need novel approaches to implement existing therapies and implement the prevention guidance that we have and that we know will work. And we need scalable health system and policy level solutions with rigorous evaluations to address the growing burden of cardio-kidney metabolic syndrome. I'd like to end here and happy to take questions later.